about hormone replacement therapy for men in the next couple of months. Next month I'll have a question and answer session. I need a little break from trying to gather data for a presentation. So the question is why hormone replacement therapy? And if you understand what's been happening over the last, let's say, 30 years, most doctors are very reluctant to give hormone replacement therapy. They say it's bad, it increases heart disease risk. So we're going to explore all of that. But the question is why? So as you know, estrogens promote bone health. When you lose estrogens, you get osteoporosis. Osteoporosis of spine is a very important factor that leads to postural changes, and it's because of bone loss. Estrogens protect bone through many mechanisms. They prevent bone reabsorption. They make new bones formation. So in other words, they promote something called osteoclasts, osteoblasts that makes new bone. And then there are sensors in the bones that they increase so that when you load the bone with exercise, it promotes bone formation. So estrogens do all of that. So they are crucially important in maintaining your bone mass. Another important thing is that my mother-in-law, who's in her 80s, has such severe sarcopenia that she needs to be helped into a car, that she needs to use a rollator or a walker. And estrogens, or female hormones, are extremely important along with testosterone, which women also make, although at about 1/10 the amount that men make. And after menopause, as you lose estrogens, you gradually lose muscle mass. And the more muscle mass you lose, the worse your quality of life is going to be. Now, it's not surprising that estrogens maintain the health of the fat cells. So when you have estrogens, fat is deposited mostly into the hip region, and the abdomen or the visceral fat is not there. But as you become menopausal, fat starts accumulating in the abdomen. So that's visceral obesity. In addition, estrogens keep the fat cells healthy. These are healthy fat cells. They don't have dead fat cells in them. They don't have inflammation in them. And when fat cells are healthy, and you may have seen me say a lot of times to you guys, that women are protected from heart disease because of the health of their fat cells. So estrogens increase the health of the fat cells so much that when a woman eats fat, the fat which gets dumped directly into the bloodstream is rapidly packed into the fat cells. So very little fat is left in the bloodstream. And when very little fat is left in the bloodstream, it doesn't get into the blood vessels, it doesn't get into the liver, it doesn't get into the pancreas. So this is called visceral obesity. This leads to blockages of the blood vessels of the heart. So premenopausal women have high levels of good cholesterol, low levels of fat, but as they become menopausal, the fat cells become unhealthy. The triglycerides or the fat you eat are not packed in, so they remain in the bloodstream as high triglycerides, and your good cholesterol goes down. Now, estrogens also improve the function of your insulin. So one of the important things I want to tell you is that this is going live on YouTube. So if you give your email address to Nina, she can send you a link so that you can watch it later if you missed something. So
it's on Facebook group as well.
Oh, the link is there on the Facebook group as well, yes. So estrogens enhance insulin sensitivity. What they do is that there is something called GLUT4. GLUT4 is a pore that lets sugar get into the cells. And so less sugar is left in the bloodstream, more sugar goes into the cells and can get stored. We already talked about insulin improving estrogens improving the health of the fat cells, and this action is also to some degree mediated by inflammation, and estrogens reduce the production of inflammatory cytokines. These are molecules that promote inflammation, that cause macrophages, white blood cells to get into the cells, which damages, if they're getting into the adipose tissue or fat tissue, damages those tissues. Now, I put this slide up saying that there is a decline in estrogen levels as women age. So it peaks somewhere in the 30s, it's pretty robust in 40s, starts declining by age 50, and then gets lower and lower and lower. And the damage in these years to your bone mass, to your muscle mass, to redistribution of fat, to occurrence of diabetes is quite strong. So declining estrogen levels will cause insulin resistance. That means insulin doesn't work as well, increases blood sugar. When insulin resistance is there, insulin levels increase. That's called hyperinsulinemia. When insulin levels are very high, you have hunger and cravings. You also, as we have pointed out, get visceral obesity. Because you have high amount of triglycerides, because insulin is not working well, because HDL is low, postmenopausal women are at higher risk of heart disease. So they are protected until menopause, but they catch up rapidly with men in the first 10 years after menopause, because the protection to the vessels and to the heart is less. Now, I'm a cardiologist, and so I was a little concerned about putting up this slide because I'm not an expert at any of this. So not only is there muscle mass loss, not only is there bone loss, not only is there fat redistribution, increased risk of heart disease, with this you get brain fog, you get hot flashes, you lose hair, the skin loses its elasticity, there is depression, there is sexual dysfunction, there is weight gain. So all of these things will alter your quality of life. So before we say, hey, in postmenopausal women, we need to figure out whether we can give them estrogens. We need to understand how estrogens work, how are they synthesized in the ovaries, what happens to a woman in a reproductive life cycle. So in this slide you see that there is a connection between the brain, the hypothalamus, that is releasing a certain hormone. It's called Gonadotrophin releasing hormone. And the pituitary gland, which is there at the base of our brain, which makes certain hormones called luteinizing hormone and follicular stimulating hormone that come and act on the gonads, the ovaries in women and the testes in men. And in women they make estrogens called estradiol and progesterone. So these are the sex hormones. So if we take reproductive years of a woman from 13 to 45, and this is a diagram of the ovary, and as you know, there is a menstrual cycle of 28 days, and the menstrual cycle in the early part starts with what is called a follicular phase. So in the early follicle, this is an early follicle which has an egg inside it, but it is immature. And in the early follicular phase, the FSH that is coming from the brain is acting on it, and it is maturing the follicle. And as it's maturing the follicle, this follicle starts to synthesize estrogens. As the follicle gets into the later stages, the estrogen levels increase. And as the egg is, or the ovum is about to mature, the estrogen levels peak. These peak in estrogen levels is sensed by the brain, and it gives a signal through the luteinizing hormone to cause ovulation, which is happening right at around 14 days, plus or minus a few days. And after it gives rise to the ovum, the follicle then changes into something called the corpus luteum. And corpus luteum is what makes progesterone. So why is progesterone needed? Progesterone is needed so that the uterus becomes ready in case there is conception to support pregnancy. But if no pregnancy occurs, then this corpus luteum involutes and becomes corpus albicans. In other words, it becomes a scar. So in all these phases, you want to see what estrogen is doing, what progesterone is doing. So let's look at that in the new slide. So these are brain hormones, but we're going to focus on estrogen and progesterone based on the cycle that the woman is in. In the early follicular phase, early part of menstruation, estrogen level is low to moderate. Pre-ovulation, it peaks. The progesterone in both these phases is very low. In the luteal phase, estrogen is declining, it's coming down. The progesterone level is high. And at the time of menstruation, both the estrogens and progesterone are low. They are quite low. So this is an important aspect, and we have talked about it before, and that is called agonist-mediated receptor downregulation. That's a lot of very complex words, so I want to break that down. What does that mean? Let's take an insulin and an insulin receptor. When insulin comes and binds to the insulin receptor, the receptor downregulates. The more the amount of insulin in hyperinsulinemia, the more the downregulation of receptors. The receptors go away. And this point I'm making because it will become important when we look at hormone replacement therapy. Is it cyclical or is it continuous? So we'll get to that in a point, but nature has designed a menstrual cycle such that there are about 3 to 4 days of very low estrogen and progesterone levels for there to be recovery of the estrogen receptors, for there to prevent continuous stimulation of the estrogen receptors. Now, I also wanted to make sure that you understand that testosterone is also made in women, and a lot of replacement therapies these days also incorporate not just estrogen but testosterone also. It's made at 1/10 the level of that in men, and it's made both in the follicle as well as in the adrenal gland, which sits on top of the kidneys. In a premenopausal woman, the follicle and the corpus luteum make more estrogens, and also testosterone. But in a postmenopausal woman, the testosterone is produced more by the adrenal gland than by the ovaries. So as you come to perimenopause, the ovaries are losing their follicles, they are making less estrogens. The brain is sensing that, hey, the ovary is not producing enough estrogen, so they increase the stimulation to the ovaries by making more FSH, which is the follicular stimulating hormone, because they think, hey, I want to push it and make it work a little harder. And this leads to these symptoms, and ovulation, of course, becomes sporadic. You don't get ovulation, cycles become irregular. Menopause is defined as somebody who has had no menstrual cycle for 12 months. So if you've had no menstrual cycle for 12 months, what is happening to your hormonal levels? So the brain hormone levels made in the pituitary are very high because estrogen and progesterone are required to suppress them. Since there is no estrogen and progesterone, the brain increases these levels. The estrogen levels fall, the progesterone levels become undetectable, and the testosterone levels also fall. They become low normal early, but they fall more later on. This is a normal ovary with a normal fallopian tubule. The ovary becomes atrophic, it becomes smaller because it doesn't have enough follicles. Now, since we are cardiologists, I want to talk about and reiterate what are the benefits of estrogens on cardiovascular health. We talked about that since it improves the health of the fat cells, it improves the quality of your cholesterol. It increases your HDL, it reduces your triglycerides. It also acts on the blood vessels themselves. The lining of the blood vessels have machinery to make nitric oxide. So estrogens go and make nitric oxide. So that's the reason why women have blood vessels that are more capable of vasodilatation. They increase in size. And that's one of the reasons blood pressure is better controlled in premenopausal women than in postmenopausal women. It reduces inflammation. It reduces blood clot formation. It keeps the blood vessels healthy because it prevents the growth of smooth muscle cells that increase the thickness of the blood vessel. It also improves the mitochondria, which is the engines of all our cells. So when you lose estrogens, your cholesterol quality goes bad, the lining of the blood vessel doesn't function well, the blood vessels become stiffer, this is called hardening of the blood vessels, your inflammation increases, and the potential for vascular disease increases. So when you know that when absence of estrogen causes all of these problems, why didn't we replace it? Why is it that we said, hey, in the last 30 years, I hesitate to ask how many women are on ARD because I don't want you to volunteer that information. But almost no cardiologist, no physician feels comfortable giving hormone replacement therapy. And the reason for that is this clinical trial. This is called Women's Health Initiative, WHI trial. And I think almost $1 billion was spent on this. In addition to that, there's another trial that I have not included, which is called HERS, replacement of estrogens in postmenopausal women. So in both these trials, so in this trial there was about 16,608 patients or healthy women, postmenopausal women, who had an intact uterus. That is their median age. And since this trial was started very early in the 70s and 80s, they didn't have bioidentical estrogen. What estrogen they had is what is called conjugated equine estrogen, which is from a pregnant mare's urine. And they didn't have bioidentical progesterone. They had Medroxyprogesterone acetate. So this is synthetic progesterone. There was an 8.5-year planned follow-up, but it was stopped at 5.6 years because a lot of bad things were happening. There's also a 20-year surveillance of the study that we'll talk about, and the primary endpoint was whether heart disease would increase and whether breast cancer would increase. So what happened? This is what killed hormone replacement therapy in my mind, but you can see that coronary heart disease, which is non-fatal myocardial infarction and coronary artery disease deaths, if you looked at 10,000 women years, 7 more women died from this. I'm surprised more did because of all the things I'm going to show you. Stroke, 8 more women had strokes. Blood clots in the lungs, 8 more women had. Invasive breast cancer, that was about another 8. The only benefit was in prevention of hip fracture and colorectal cancer. There was, for 10,000 women, there were a net 19 adverse events. If you even if you took out the beneficial effects. Very sobering. So here it's talking about 20-year follow-up. Breast cancer mortality still remained high. All-cause mortality was overall neutral. It didn't really change, did not benefit. Fracture reduction was there, but if therapy was stopped, fracture benefit stopped. And excess cardiovascular benefit remained as long as women were on the replacement therapy. So the question is, why did this harm come about? These are all the harms. There was more harm than benefit. There was more breast cancer, more strokes, more blood clots, and modest increase in heart disease, despite a slight reduction in fractures. So why did this come about is an important question. So the reason it came about, we feel, is because they used synthetic estrogens. These were not bioidentical estrogens. They used synthetic progesterone, which is called Medroxyprogesterone acetate. And another important factor is that when a woman makes estrogen, it's made in the ovaries. And when it's made in the ovaries, it gets dumped directly into the systemic circulation. It gets dumped into the blood vessels. It gets dumped into the blood. It doesn't go into the liver. Whereas when you ingest a drug by mouth, invariably it goes through the portal circulation into the liver. So I'll get to that slide. So here is somebody ingesting a drug. This drug then gets into the liver first because of portal circulation. And then liver alters it, and liver itself gets altered, and then it releases into the systemic circulation. So this conjugated equine estrogen, which was called Perimenopause, goes through liver metabolism first, which is called first-pass metabolism. It increases the coagulation factors. The liver jacks up the production of factors that make the blood more at risk of clotting. The liver increases triglycerides and reduces HDL after exposure to estrogens. And the liver increases the production of inflammatory markers. So if you look at synthetic estrogens versus bioidentical estrogen, which is called estradiol, this is a mix of 10 different equine estrogens. It's got very strong first-pass metabolism in the liver. These are mostly oral tablets. Very few other formulations are present. On the other hand, this one is a single molecule which is identical to what our ovaries make. Even if you take it by mouth, it doesn't have as strong a first-pass metabolism. But new formulations are transdermal. So you get a patch on the skin so that it bypasses the liver. And the stroke risk is much higher with this. Stroke risk is neutral. Inflammation is much higher. Poor cholesterol quality is much higher with this. And much higher risk of breast cancers. So this is, I'm surprised that the early postmenopausal woman is so healthy that despite us giving them a drug that increased coagulation factors so much that the number of events were not that high. I would have expected that more women should have had bad outcome, because when you look at it, this is a coagulation factor that initiates coagulation. It increased by 20 to 40%. This is factor 10, which works activating coagulation inside the body, increased by 10 to 25%. Prothrombin increased by about 5 to 15%. Fibrinogen increased by 10 to 25%. And the proteins that dampen or reduce the risk of blood clot, which is called clot blusters, like proteinase and antithrombin 3, decreased by 20 to 50 and 5 to 10%. So it's surprising that more women didn't have blood clots, more women didn't have strokes, more women didn't have heart disease. Now, the next question you ask is that why not give estrogens alone? why should you not give estrogens alone? Why do you need to combine that with progesterone? So if you give estrogens alone, it's a very strong mitogen, which means that it's a very strong cancer-inducing hormone, at least in the uterus. The uterine lining keeps increasing. And if unopposed, it increases by 3 to 10-fold, and this can increase the risk of cancerous transformation about 20 to 30% of the time. So in order to reduce the effect of the estrogens on the uterus, you give progesterone, because progesterone immediately converts the lining of the uterus to what is called secretory. It shuts down mitosis, which means it shuts down cancerous transformation. It promotes apoptosis. If cell is not very good, it helps it go through natural cell death. So it's shrinking and stabilizing the endometrium. It is reducing cancer risk, and that's why progesterone is given. So this is again reiterating that when you have estrogen alone, you are promoting cancer risk because you're promoting mitosis. You are activating certain key genes that increase cancer risk. And progesterone in this situation is protective. If you only give it, like if you look at the menstrual cycle, after ovulation until menstrual cycle, there is about a 10 to 14 day period. So if you give it only in that duration, progesterone is protective. So you would say, okay, I'm protecting the endometrium by giving progesterone, which is good. But what's happening to breast tissue? So in other words, does progesterone reduce the risk of breast cancer to the same degree as it is reducing the risk of uterine cancer in women? Unfortunately, it works exactly the opposite. Progesterone is reducing uterine cancer risk, but it synergizes with estrogen receptor alpha, and it starts proliferating the ducts in the breasts, increasing cancer risks. It promotes certain genes that would increase breast cancer risk, and it leads to what is called increased mammographic density. The breasts become very thick, which is another precursor of increased cancer risk. Now when we talk about progesterone, we are talking about synthetic progesterone, the medroxyprogesterone acetate. Whereas the bioidentical progesterone, which is called micronized progesterone, fortunately doesn't have any of these side effects. So it should say, what if a woman has already had a hysterectomy? So in other words, some women go through hysterectomy because of fibroids, because of uterine bleeding. So if this woman is postmenopausal, if you give them estrogens, does it carry risks, the same risks, or is there benefit? Because this woman does not need progesterone. They don't need progesterone to protect their uterus. So in the Women's Health Initiative, there were about 11,000 women who did not have a uterus. That was their mean age. They just got the Premarin, the conjugated equine estrogen. The planned follow-up was for 8 years, stopped at 7.2 years, surveillance continued for 20 years. Heart disease and invasive breast cancer was the primary endpoint. Heart disease was neutral. Clotting increased because estrogens increase clotting, like we talked about. They are going through first-pass metabolism in the liver, they're jacking up the coagulation factors. That didn't get protected, but look at invasive breast cancer. In hysterectomized women who did not have a uterus, hormone replacement therapy reduced breast cancer risk by 6 for every 1,000 women treated. I don't have that out here, but that's amazing. It also reduced hip fracture risk because, of course, it increased bone density. Breast cancer incidence went down by 22% at 20 years. Mortality went down by 44%. Overall mortality was not different. And at 20 years, for some reason, after the first few years in which women got weeded out who had heart disease mortality also reduced quite dramatically in that 20-year follow-up. So now the question comes about is that was then. What is it now? Now technology has progressed. We can make bioidentical hormones, and we can make bioidentical estrogens as well as progesterone. Do these things increase breast cancer risk? Do these increase uterine cancer risk? Do they protect the heart? Do they cause blood clots? So let's take a look at that. Unfortunately, that information is not as robust as you think, because the desire to give hormone replacement therapy went away from the medical mainstream. Gynecologists are reluctant to prescribe HRT. There are very few. Like in this area, I would know maybe like one or two who are willing to delve into hormone replacement therapy. Especially in older women, especially in women 10 years after menopause, because the data is so low. Early on, they would be quite willing in the perimenopausal periods. So these are the different kinds of transdermal estrogen patches, and I would recommend nobody take oral estrogens. Even though bioidentical oral estrogens don't have as much liver, first pass liver metabolism, I think the way to take estrogens is oral. I think the way to start it is at a very low dose, which is 0.14 milligrams per day by a patch. But there are all kinds of different formulations that even go up to 0.1 milligram per day through their patch. So these are the different estrogens that are available from transdermal approach. Micronized progesterone, which is bioidentical progesterone, is available in oral form. It's either 100 or 200 milligrams. So the amount of data with bioidentical estrogens is very limited, and I'm quite surprised about that. So this is a study, 2012. Only 727 healthy women, very young, 42 to 58 years. So that means all of these women were within 10 years of their menopause. They were into three groups: an estrogen patch plus micronized progesterone. This is the Perimenopause, the Mayer's or the conjugated equine estrogen. By that time, they had figured out that medroxyprogesterone acetate or Provera or Depo-Provera was very bad. So they were unwilling to do a study with medroxyprogesterone acetate, thank God, and they used micronized progesterone, which is called P4, and then there was a placebo group. 4 years of treatment, and because it is such a small population, they cannot look at outcomes. How many women died, how many women got breast cancer, how many women have heart attacks. So they have to resort to what is called a surrogate endpoint. A surrogate endpoint is something that tells you, hey, these women are at higher risk of vascular disease. So when they're looking at the thickness of their carotid intima. So what happened? So you're with an ultrasound probe, you're checking the thickness of this intima, and with a scan that like we do, they're checking whether people had calcium buildup in the blood vessels of their heart. So in terms of CIMT, which is the thickness of the intima, no difference. In terms of coronary artery calcium, no difference in the three groups. Of course, symptoms of menopause were improved, like hot flashes and mood and other functions. Quality of lipid, when you gave the equine estrogen, the Perimenopause, the quality of lipids went bad. When you gave the patch, the lipids were neutral. It did not change the triglycerides or the HDL, they were neutral. Now, For one reason or the other, they did not find increased risk of blood clots, but this was a small group. But blood pressure went up in the group that got the conjugated equine estrogen, whereas the patch did not increase blood pressure. Breast cancer, there were 0 risks of breast cancer, which I'm surprised. I would have thought that the equine estrogen group would have a higher risk. And there was 1 non-fatal stroke in the equine estrogen group, none in the other group. So basically, you don't know the safety of this drug from outcomes data. Now, the French people have a very large registry. They have registry of many, many women on estrogen groups. In this registry, there is about 54,000 women, and they're looking at breast cancer risks by the kind of progesterone that is being used. So if you see here, they now resorted to E2. E2 means the bioidentical estrogen. They are no longer using the conjugated equine estrogen, which is called Premarin. So this is E2 plus the Medroxyprogesterone acetate, which is the bad kind of progesterone, not the bioidentical. The risk of breast cancer was high, relative risk was 1.69, and it didn't cross the midline. In other words, it was not below 1. On the other hand, if you used E2 with the bioidentical progesterone, there was no excess risk. This is another 80,000 patients. Breast cancer risks increased with synthetic progesterone, which is NPA. Micronized progesterone, it was neutral. Then they updated it at 98 or almost 100,000 women that started hormone replacement therapy 5 years after menopause. The E2 with micronized progesterone, that means bioidentical hormone, was neutral. In another study, they reported in 73,000 patients, confirmed the safety, the 10-year excess of breast cancer per 1,000 patients treated. When you use the Medroxyprogesterone acetate, which is the non-identical form of progesterone, the risk was 7.7 per 1,000 higher for 10 years, whereas for the bioidentical hormones, it was only 0.6. So in other words, the bioidenticals were much safer. Now this is the risks of venous thromboembolism. VTE means venous thromboembolism. When you use the conjugated estrogens or estradiol by mouth, the risk increased because this is much greater patients that they are studying. Whereas transdermal estradiol, that means the patch, the bioidentical patch, there was no excess risk. So how would I summarize this? If we look at conjugated estrogens, which is the mare's urine estrogen, and the medroxyprogesterone acetate, which is a synthetic progesterone, and compare them with bioidentical estradiol, which is transdermal and micronized progesterone, breast cancer risk increases here, it's neutral. Stroke risk increases here, it's neutral. Cardiac, there is harm in this group, it's neutral in this group because we don't have data whether it benefits. Blood pressure goes up, triglycerides goes up, inflammation goes up in this group, it's neutral on blood pressure and lipids. Muscle mass and quality of life will improve in both. So overall balance, nobody was going to use this, it's negative. I think oral should not be used, transdermal should be used, and I think it has a favorable safety profile. So now here I want to get into and talk to you about to what level was estrogen increased by these patches, and compare that to a premenopausal normal woman, right? You're putting a patch on. I want to see how much the estrogen went up in these women. Now, if they used a patch of 0.05 milligrams per day, and this was continuous, a human menstrual cycle is cyclical. There is about a 3 to 4 day period in which there is very low levels of estrogen and progesterone. This is not what these people who designed these trials did. They gave estrogens continuously. They did not give a 4-day period without estrogens, and I have no idea why. So if you look at it, it went to 47. That was the median estradiol levels. It is similar to the mid-follicular range, that means in the middle of the cycle. And with oral, it's different because oral goes through liver metabolism. So the amount of bioidentical estrogen that is released into the bloodstream is lower when compared to the patch. And some of this estrogen is converted to something called esterone. So the estrone levels were much higher. And estrone is about 1/10 as potent as the estradiol is. In women who did not get it, the estradiol levels were low, the estrone levels were very low. They reflected postmenopausal levels. Now here are levels in a healthy woman going through her menstrual cycle. During menstruation it is as low as 10. If you go back here, these levels were 47. So in other words, they were not low at any point during the cycle. And if estrogens are not low at any point during the cycle, they will increase mitogenic risk. They will increase the risk of cells that have mutations, that are senescent, that are aging, and they can get transformed into cancerous cells. On the other hand, if you give them a break, like nature does, for 4 days, the risk may have been lower. So these are different, there's a peak out there of about 150 to 300 just before ovulation, and then as the corpus luteum is present and it's getting older, the levels start falling. Now fortunately, micronized progesterone levels, most people give progesterone not every day, although some gynecologists say take it every day. I think they should only be given for the 10 to 14 days in the later part of the cycle. Giving it every day, I'm not sure is that necessary. But the levels, blood levels of progesterone were pretty comparable to what you would not normally find in a healthy young woman. So this is the point I wanted to make here with this slide, is that there is a cycle in the human body for estrogen levels to rise, peak, start falling, and then be almost absent during the period of menstruation. The progesterone levels rise after ovulation, but if there is no implantation, if there is no pregnancy, the levels fall during menstruation. So this should be duplicated. This pattern out here should be duplicated in hormone replacement therapy, and I don't know why there is no study other than one study that is talking about rhythmic hormone replacement therapy. Hormone replacement therapy that is rhythmic. So this is the only one, and it happens to be done by a physician who shares my name. Only 29 women, the 28-day cycle mimicking the menstrual cycle, follicular, ovulatory, luteal, and then 3-day free interval without hormones for menstrual cycle. That's the dosing early on, and then late follicular phase. This is when ovulation is supposed to occur, and this is during the luteal phase. And then a 3-day period in which no estrogen is given. Progesterone was given only for a 10-day period after ovulation. So what happened? The peak levels were high. The nadir of levels at 28 days were very close to what they were 10. I mean, 10 is the lowest. These women had 15. Very close to what a normal menstrual cycle looks like. Now, 93% of patients had complete relief of all their symptoms, quality of life improved, there was no strokes, no blood clots, and no breast events, but there were only 29 patients, so you can't make much out of it. So now let's talk about what is the benefit of getting estrogens. So in other words, what benefit do you get? I mean, I'm not going to talk about improvement in mood, improvement in sexual function, improvement in libido, but I'm going to talk about things that are important for quality of life, like bone mass, like muscle mass. So this is a study on bone density. So this is what is called a seminal study. This was the first study that was done. 72 women were enrolled. This was the old Premarin, the conjugated equine estrogen. Forearm cortical bone mineral density every 6 months for 3 years. If you were not treated postmenopausal, you were losing bone mass by 3% every year. 3% every year. If you took this Premarin, this old form, you had a 0 to 1% increase. So in other words, you didn't lose bone, you kept the bone, you actually increased. You also had significant relief from the symptoms associated with menopause. And this study was cited so that there could be approval of estrogens for treatment of osteoporosis. Now this is a meta-analysis. Meta-analysis means that you put all the studies together and see what is the effect of hormone replacement therapy on fracture prevention. 192,000 patients, postmenopausal women. Clinical fractures reduced significantly, that's the odds ratio. If it's below 1, that means you had significant reduction. Hip fractures reduced, vertebral fractures reduced. The transdermal bioidentical estrogen with micronized progesterone was much safer than the older forms. You would have expected that. Great. Now sarcopenia. You want to avoid sarcopenia because I don't want people to become like my mother-in-law and have her grandchildren help her into a car, get her up the stairs. So sarcopenia messes up your quality of life. So in this study, 4,200 odd patients, okay, they were divided into none, 1 to 12 months, greater than 13 months of hormone replacement therapy. This is imaging appreciated skeletal muscle mass, IDEXA scanner, DEXA scan, was with weight. With 13 months, there was higher skeletal muscle mass. In other words, these women preserved and improved the skeletal muscle mass with a significant odds ratio. The benefit was strongest in women less than 65 and women who were already somewhat fit.
How much is sarcopenia affected by hormones and how much is it by lifestyle? Because you don't see a lot of older people in the gym.
Very important question. The question is that, hey, can you negate the effects of menopause by lifestyle? So it's not just resistance training. Women should increase resistance training, but also the amount of protein you eat. Because if you don't eat protein, you're not going to build bone, you're not going to build muscle. So postmenopausal women should focus not just on resistance training, but increasing intake of high quality protein, probably like we talked in the supplements presentation last time, take creatine, take protein powder, I like whey protein. So that's an important question and I was going to get to that in a bit.
Oh, sorry.
No problem. But important. I want you guys to interact. But I want to also leave you with the thing that I don't know all the answers. This is not my area of expertise. I'm interested in this area because I hate to see my patients lose muscle mass, lose bone mass. And I want to work with a gynecologist who is ready and will consider prescribing hormone replacement therapy for my patients. But I also want to ask the contrary question. Is menopause protective? Does menopause protect women? Nature doesn't do anything that is all wrong, right? I mean, I think it does some parts right. So, when the breast tissue gets older, it has DNA damage, it has mutations. So older breast tissue doesn't respond to estrogens the same way as younger breast tissue does. Older breast tissue may be at higher risk of cancerous transformation. Older uterine tissue is the same. It is, the lining is older, there is more somatic DNA mutation, so there may be higher risk of cancerous transformation. A younger blood vessel is very different than an older blood vessel. An older blood vessel has calcium, has plaque, is stiff. Does estrogen do the same good things to it from the standpoint of endothelium? Is unknown. These are things that need to be explored. So menopause can be protective because it's genomic housekeeping. In other words, it means that the estrogens are going down because the breast tissue and endometrial tissue is at risk of cancerous transformation, and the decline in estrogen is protective. Same with the blood vessels. The blood vessels are stiffer, are calcified, they have plaque. And so the benefit of estrogens may be very early after menopause, certainly within the first 10 years after menopause. If you're starting after 10 years of menopause, like let's say at age 60, is the risks higher or the benefits lower? And these are questions that need to be explored. We don't have good answers to that. Now there's also an evolutionary perspective. And I found this very interesting because you don't want the mother and the daughter to have pregnancies at the same time. You don't want mother and daughter-in-law to have pregnancies at the same time because it creates very strong and bad social dynamics. It's also sharing of resources and stuff like that. So nature may have designed that, the menopause, to prevent something like that. But menopause is not entirely protective. So I don't want you to walk away thinking that, hey, I'm saying menopause is protective and hence don't consider HRT. I think modulated HRT is very important because sarcopenia is very bad for quality of life. That changes in your abdominal fat, that when your health of your fat tissue goes away, you are at risk of heart disease. When you lose bone mass, you are at risk of fractures that completely destroy the quality of life dramatically. But I wanted to leave you back with an evolutionary perspective by looking at the fact that humans are very unique in the mammalian species to have menopause. Most animals don't have menopause. They are reproductive almost until they die. Only the last 2% of their life is without children, which is amazing, without offspring. However, there are certain other mammals that go through menopause, and so this is a study, the evolution of menopause in toothed whales. So they took whales, and I want you to give me a little indulgence. All these whales with these blue diagrams don't have, with these blue lines don't have menopause. But the ones with red lines have menopause. So in other words, not all whales have menopause. So now what these researchers did was that they looked at the length of the whale. So out here is the length of the whale, and out here is lifespan. So the red are the whales that have menopause, the blue are the whales that do not have menopause. What do you see out there? Who is living longer? The whales with menopause or the whales without menopause?
With menopause.
Whales with menopause. So why can't humans keep the longer lifespan? Why can't we keep longer lifespan? And since we have the science behind us, why can't we use judicious hormone replacement therapy along with resistance training, high protein intake to avoid sarcopenia? Always use bioidentical estrogens, low dose, Perhaps this is a very easy decision in women who have lost a uterus, because your risk of endometrial cancer is very low or non-existent. Micronized progesterone is the only one to use, perhaps only for about 10 days, 10 to 12 days of the cycle with intact uterus. I hope that some researcher says that, hey, I want to consider using rhythmic hormone replacement therapy to mimic a cycle. You don't have to go to the peak levels like in normal, but at least you got to give an interval 3 to 4 days free of estrogens. And the newer regimens, at least based on many studies, some of them like the E3N trial that has somewhere between 70 and 100,000 patients, is consistently showing no increased cardiac, vascular, stroke, cancer, or clotting risk. So I think that in this area, there are a few physicians that do give hormone replacement therapy from OB/GYN standpoint. And so I want you guys to always initiate that conversation with them. And as a cardiologist, we will be evaluating you on an individual basis and be supportive of your decision. All right, thank you.